Yep, starting now.
Yep. Okay. So welcome everybody to this webinar on access to palliative and end-of-life care for people with neurodegenerative conditions. This is part of the National Cross-Arc Palliative and End-of-Life Care Collaboration webinar series. So the Cross-Arc collaboration is co-led by Professor Irene Higginson from the South London ARC and myself from the East of England ARC, ably supported by Meg Hogoglu in making sure we bring these all together. The purpose of the ARCs is to drive collaboration, maximize impact, deliver impact, and provide expert advice. Apologies. The purpose of the cross-ARC collaboration is to deliver on these things. And as part of that, we have this webinar series in order to bring people together to discuss topics that are of relevance to us. So I'm really pleased to welcome you to today's particular webinar, which, as I've said, is about access to palliative and end-of-life care for people with neurodegenerative conditions. And this has been jointly organised by the National Collaboration, along with the NIHR Policy Research Unit in Dementia and Neurodegeneration, and the NIHR Policy Research Unit in Palliative and End-of-Life Care. So your session today, although I'm opening and closing it, it's going to be chaired by Emily Adams from University of Exeter. Emily is the Stakeholder Engagement and Impact Manager of the NIHR Policy Research Unit in Dementia and Neurodegeneration, which is known as DEMPRU for short. And you're going to have presentations from 4 field leaders. So Jan Oyebode, who's Professor of Dementia Care in Applied Dementia Studies at Bradford and Deputy Director of DEMPRU. And Karen Windle, who's Professor of Healthcare Research and Impact at University of Ulster and part of the leadership team for DEMPRU. Catherine Evans, who's the Interim Director of the Cicely Saunders Institute and Clinical Professor in Palliative Care at King's and Honorary Nurse Consultant with Sussex Community NHS Foundation Trust. And finally, Andy Bradshaw, who's Research Fellow at Cicely Saunders Institute and is a Network Manager and Researcher on the Empower Dementia Network. So just to ask of you that following the presentations, we'll have a live Q&A session, which will be chaired by Emily. If you could please use the Q&A function to post your questions, that will be really helpful. And then we will close the end of the session with some brief information from me about the next webinar and a very brief evaluation. So I am going to hand over to Emily. Stop sharing, there we go. Who's going to chair the session? Over to you, Emily.
Amazing. Thank you so much, Morag. Thanks for introducing us to today's webinar, and thanks to everyone today for joining us to discuss the important topic of palliative and end-of-life care for people with neurodegenerative conditions. I'm delighted to be chairing today's webinar and will do my best to keep us to time and make sure we've got lots of time at the end for a live Q&A. So as Morag said, please do get your questions into the Q&A function and we'll make sure we answer as many as possible. So the structure for today's session, we'll be hearing from our wonderful speakers and then we'll move into the Q&A. If we do not manage to answer all the questions, we will endeavour to get back to you and get some answers to those questions and take those away with us. So I'm delighted to firstly hand over to Jan Oyebode, Deputy Director of DEMPRU Exeter, and Professor Karen Windle, a member of the DEMPRU leadership team, to kick off with their first presentation.
Thank you, Emily. So we have some slides. I'm Jan Oyebode. I'm going to introduce the first part of the webinar where we're reporting from some work we've been doing within DEMPRU Exeter. We are one of 2 policy research units on dementia and neurodegeneration that were funded in the last round of funding from NIHR for policy research units. And our role is to provide and collate research evidence to support policy making in the Department of Health and Social Care and its arm's length bodies. And as you can see here, although our title is DEMPRU Exeter, and we have a hub at Exeter with our director, Linda Clare, administrative and other staff, including Emily, We also have a number of other collaborators around the UK. So we are representing England and also have Karen in Ulster and have quite a good range of geographical distribution. So the particular project that we're going to talk about today, the work we've been doing, has been focused on Parkinson's disease. And we were asked by Department of Health and Social Care to undertake this work as a responsive project because they were particularly interested to understand the research landscape in the Parkinson's disease area and to see where research was concentrated, where grants were being given, and where funding was going and what this was leading to in terms of Parkinson's disease research. And as we've undertaken this project, we've become particularly interested to see the lack of research funding on end-of-life care, and Karen is going to take us through some of that. But that finding drew us together with the Policy Research Unit on Palliative and End-of-Life Care and led to us thinking together about what needs to be done to improve this area. And it was those joint discussions and the connection with the ARC that led to the webinar today. So the aims of this particular part of our work are to understand the nature of the research evidence across prevention, diagnosis, treatment and care for people with Parkinson's and related conditions, and understand where and how the research funding is being used. So to do this, we've had two major parts that we're going to talk about today, one involving publishing these research studies and the other involving consulting both professionals and people with lived experience about their views of the research priorities and their experiences. So in terms of publishing, mapping published research studies, we've looked across Parkinson's disease and allied conditions, which you can see listed on the slide here. And we then searched for all the Parkinson's related research that had been published in English in the last 5 years. This led to us needing to look through an enormous number of abstracts of research, and we did that to see how many of the research records we'd found could be categorized according to one of the themes of prevention, diagnosis, treatment, or care. And we're going to take you through what we found in terms of those 4 broad headings and then where end-of-life care fits under those headings. So I'm going to hand over at this point to Karen, who's going to talk you through some of those findings.
Thanks very much, Jan. And next slide, please, Emily. Just check we're on the right slide. Excellent. So of the 31,000 odd papers that were found from the search, around 46% of these focused on the 4 themes of prevention, diagnosis, treatment or care, including end of life, while the remaining 54% were focused on preclinical studies, for example, animal models, or on the disease mechanism itself. We were therefore left with around 14,000 papers that were relevant to the 4 themes, and of these, just over 12,000 focused on primary literature, while around 2,000 was some form of systematic review. And in this presentation, we're concentrating on primary literature. Now, you can see from this table that the main focus of the papers, almost 2/3, concentrated on treatment, and that was in the main drug treatment or deep brain stimulation. A quarter discussed diagnosis, while less than 5% explored prevention, mainly concentrating on environmental factors, and a similar small number explored care, including end-of-life care. Next slide, please, Emily. So just before talking a little more about the end-of-life focus within the overarching literature, it might be helpful to understand how we were defining the theme of care. Now, within this, papers were included if they focused on the experience of living with the Parkinsonian condition or being a carer for someone living with the condition. If the papers discuss the needs and support necessary to live well with the condition from diagnosis to end of life, they were included, as well as if they highlighted or described care systems and pathways, the organisation and provision of services, resource utilisation and costs. And here you can immediately see the paucity of primary research papers that discuss palliative or end-of-life care across the different conditions. Of the finally included 663 articles, only 48 discuss palliative or end-of-life care. And in addition, for some of the conditions, palliative or end-of-life care has simply not been explored. By far, the majority of the small number of papers concentrated on Parkinson's disease, 39 out of 48, around 80%, with only 6 exploring Lewy body dementia. Next slide, please, Emily. So, in narrowing the focus of these papers, the majority looked at palliative care or end-of-life support, with small numbers exploring assisted dying, place of death, and advanced care planning. The latter, advanced care planning, seems to be a real absence, given that we know from those living with the condition, as well as carers, how important this particular mechanism is in ensuring they can detail the extent of support they want and where they would wish to die. Next slide, please, Emily. So, given that there were less than 6% of papers looking at care per se across Parkinsonian conditions, and of these only 48 were found that discuss palliative or end-of-life care, we carried out a wider consultation. Next slide, please, Emily. We held 2 online consultations, one with a clinical academic who had cared for a parent with Parkinson's disease, and the other who had been diagnosed with Lewy body dementia. We had hoped for more. 6 individuals did sign up, but it's a challenging area of discussion. And we were very grateful for the insights that the carer shared with us. We also talked to professionals, and this separate consultation process incorporated 6 individuals, and these were old age physicians, a specialist Parkinson's disease nurse, third sector staff from the different Parkinsonian conditions support charities, and an end-of-life doula. Next slide, please, Emily. So within the consultations, our overall question that we posed was, what does good palliative and end-of-life care look like for someone with Parkinson's conditions? Next slide, please. Now, from the analysis of the discussions, it was clear that for our carer, an integrated pathway was essential, with the emphasis on planning for the future. As with much research that explores the structure and process of clinical diagnosis, the expert by experience argued for the necessity of timely communication, and perhaps more important, the need for consultations that could facilitate a real understanding of the information being given, as well as providing opportunities for questions. So in short, time. They wanted time, and they wanted further consultations. The professionals themselves also highlighted the importance of communication and information. And perhaps interestingly, they discussed the need for healthcare staff to be aware of the diagnosis and trajectory of Parkinsonian conditions. And I'll come back to that in a minute. Next slide, please, Emily. So our second question within these consultation was, what challenges or gaps have you seen in relation to palliative and end-of-life care? Next slide, please. Perhaps you won't be surprised, given the previous slide, that for the expert by experience, the lack of information, communication, and service integration were all perceived as challenges in navigating care. In part, this was mirrored by the professionals, highlighting there was an absence of a Parkinson's or Parkinsonian pathway, and that navigating services by the patient or carer was made more challenging by this service fragmentation. They also sadly flagged that there are simply not enough specialists to support the necessary expert care within this field. And finally and importantly, they argued that palliative and end-of-life care was challenging, as prognostication across Parkinsonian conditions, as with all dementias, isn't yet precise. As they argued, if you can't plan for when the patient may die, it's more challenging to understand when referral to palliative or end-of-life care services may be helpful. Next slide, please, Emily. So our final question within the consultations brought together both of these discussions to ask, what do you think should be prioritised for Parkinson's related research in palliative or end-of-life care? Next slide, please. As you can see from the responses, what the expert of experience felt was important and what professionals felt was urgent were roughly aligned. Both perceived that research that could support system integration was essential, along with preparing for end of life through appropriate information and focused models of care. For the professionals, they wanted more research on prognostication. One of our professionals argued that in the main, there seemed to be a wide acceptance across health and care professionals that you don't die with Parkinson's, you die of another condition. However, as our professional argued, this acceptance needs to be challenged if appropriate and timely palliative or end-of-life care is to be provided. Importantly, for both groups, research was needed on the type of communication and information that could support the individual living with the condition, as well as their carer, to prepare for end of life, to detail what might happen in those last months and what support might be available. As our carer articulated, there's something about knowing what might happen, but also you would have support for when that happens. Next slide, please, Emily. So thank you very much. Please do post any questions using the Q&A function. And next slide, Emily. You've got all the links to the reports, and there's a couple of reports on the Parkinson's disease project that you can look at, and we look forward to picking up the questions soon. And back to you, Emily. Thanks very much.
Wonderful. Thank you so much, Jan and Karen, for taking us through that really interesting project at Denpro Exeter. So yeah, you'll see in the chat, the team have been posting some links to our report. So we have 2 reports from that project so far, and we are working on a final project report as well. So I'm delighted to now hand over to Catherine and Andy to talk to us about the Empower Dementia Network Plus.
Thank you, Emily. And thank you, Karen and Jan. You can see now in our presentation very much the sort of the segue and the synergy between the quite shocking underrepresentation of research on for adults, living and dying, in this case specifically with Parkinson's disease from Jan and Karen's work, that less than 7% of the research studies that they identified had focused on that living and dying with a progressive terminal neurodegenerative condition. So as Emily said at the beginning, my name's Catherine Evans. I'm a Professor of Palliative Care at King's College London in the Cicely Saunders Institute. I co-lead with my colleague Emma Wolverson from the University of West London, the Empower Dementia Network. So this was one of 4 dementia networks that were funded by the ESRC, the Economic and Social Research Council, that all began in April 2024. So we're going to present some of our initial work developing methods of innovative co-design for inclusive dementia care for people more severely affected by dementia needing greater support. So what we believe very much within the Empower Dementia Network is that people living with dementia are able to lead meaningful lives, that they can pursue things that matter to them and they can access the care that they need. But for all of us, as we've just seen from Jan and Karen's presentation, that there is a dearth of evidence around some of that provision of care. So the Empower Dementia Network is focused specifically on addressing the most profound and unfair and avoidable inequalities in access to high quality dementia care. Oh, can you just go back? Thank you, Andy. So this is particularly focusing on adults from ethnically diverse communities in rural areas, individuals living with multiple health conditions. And what the network sought to do was that we formed a UK-wide network, so including the devolved nations of Wales and Northern Ireland and Scotland, to tackle the very worst inequalities, very much with the intention to then promote and sustain high quality care for people with dementia. And the network really is quite unique, that it brought together individuals with lived experience of dementia, with practitioners and with researchers from primary, social care, palliative care and dementia care. So in this slide, this just gives an overview of what the Dementia Network actually comprises. So as I said at the bottom, it has created this unique and novel shared platforms across the many individuals who are both receiving care, providing care, undertaking research, and also our policymakers. So in this brief presentation, I'm just going to very focus on the bottom 2 work streams. So these have been the foundations for our network. So work stream 1 about engaging underrepresented groups in research, and work stream 2, innovating inclusive research approaches. And the reason that they form our foundations is it's very well rehearsed who is underrepresented in research and dementia care. So that, as I said at the beginning, is very much individuals from ethnically diverse groups, individuals from socioeconomic disadvantage, and individuals with more advanced dementia. So working alongside us are the 2 pillars on either side. So our pledge group, these are people with lived experience of dementia who've worked with us right from the start in writing the original proposal, in helping us to secure the funding. And then the right-hand pillar is our community partners, so both regional, national and international, who again work alongside us to very much innovate the way that we are providing dementia care to address those very worst inequalities. Next slide. Thank you. And then throughout all of that, co-production is very much a driving principle. And the reason for this is a means of prioritising equity, shared power and shared responsibility amongst all of our participants. So all those groups, be you a researcher, a practitioner or a lived experience expert, with shared responsibility. And the reason for doing that is to maximise both the diversity and the inclusivity in the way that we work. And this is very nicely summarised by a quote from Eric Deason, who's one of our lived experts who works with us. And as he says, co-production is when professionals and service users work together equally to develop, deliver and evaluate that service. So that's how we work together. So one of the first components of our innovating methods of inclusive co-production was in using creative methods. So to achieve this, we work with a fabulous public engagement specialist, Faye Watson, and she very much as researchers enabled us to think differently. So with Faye, we developed some co-creation methods and resources which are accessible through the QR code on our website. We then tested out those methods within our first co-creation workshop. This involved 38 community partners and researchers from across England. And we co-developed and tested those creative inclusive methods with the intention that they could then be used by community partners across the UK. Next slide. So those creative methods, what they comprise is sort of summarised in this slide here. So in the middle is a tool shed where we ask people to work together to be detailing what are the tools needed to address the very worst inequalities in dementia care. In the middle then to the right is the compost heap. So what are the barriers that we need to be removing? What are the things that are stopping us from achieving that equitable access to high quality dementia care for all? And then on the farthest right is the pollinators. For all of us to reflect on, well, what responsibilities do we have? How are we able to connect people? How are we able to make a difference in the way that we engage the public or our policymakers in championing the need for high quality dementia care for all? And then on the far left-hand side is our tree, where initially we called this our manifesto at this stage, where we were asking people, what are the priorities for you in the provision of high quality dementia care? And remembering that provision of dementia care is very much from that supporting well, living well, through to dying well and into bereavement. So those points of care for adults with dementia when they're needing greater support. Next slide. So those resource kits were then made available to our community partners with a video recording by Faye, walking people through how to use this resource, very much with the intention that community partners up and down the country could then use this resource to understand from their members what did high quality and excellent dementia care mean for them. So this has led to 11 co-creation workshops across the UK, involving over 170 participants, around 50% of whom are affected by dementia. So either living with dementia or they're a family carer of a person with dementia. So this enabled us very much in achieving the first two intentions of our work streams, of reaching underserved groups affected by dementia and innovating the research methods of co-production to be able to do that in meaningful ways. And what those 11 co-creation workshops enabled us to do was to build a bold vision for excellent and inclusive dementia care. And you can access that again from this QR code from our website, where we wrote a blog in relation to the workshops. Next slide, please. And then I'm going to stop there and I'm going to hand over to Andy, who's going to give some detail on the priorities that we developed from those co-creation workshops that we were then able to take to the policy labs.
Thanks, Catherine. Yeah, so just picking up from where Catherine left off there, what we did in March of this year was, in further trying to develop our vision of excellent and inclusive dementia care, we held a policy lab, and the policy lab brought together people from across primary, social, palliative and dementia care, specifically bringing together community partners, lived experts, practitioners, policymakers and researchers. And the aim of the policy lab was to assess the evidence on inequalities in dementia care, to understand what the kind of constraints and barriers already exist to change, but most importantly, really to come together to co-produce practical solutions for action that we can pursue throughout our network. And so in doing that, we spent an afternoon discussing how we can reduce the worst inequalities in care for people with dementia and their families who need greater support. And really from those conversations, it was quite clear what the answer was, and the answer was we already know what the answers are, and we really know what already works. And to summarise, it's about having sensitive relationship-centred care, but importantly having this across a well-integrated health and care system in which the workforce are trained and well supported to deliver that type of care. And so you can read there a policy lab, you can read there, sorry, a blog on the Policy Lab, which just outlines in a bit more detail what we got up to on the day itself. And we landed on, we co-produced 5 recommendations that we felt were practical and realistic in reducing the worst inequalities in care for people affected by dementia. And these were firstly to look at providing better care to people who live alone. It was about promoting relationship-centred care, addressing the economic case to support integrated and equitable dementia care, to establish a national dementia strategy in which dementia has a clear home within the health and social care system, and then really to build a dementia-aware society. And so from the policy lab work that we did and all of the co-creation work that we did with our community partners that Catherine spoke on, we were able to build our vision of excellent and inclusive dementia care, and really the foundation on which we'll pursue for the remainder of the Empower Dementia Network. And so as we've kind of moved across the different work streams, looking ahead to work streams 3 to 5, so addressing inequalities, self-care for family carers and digital inclusion, one of the real vehicles that we're going to use to pursue those different work streams are through the Small Research Project Fund that we have as part of the network. And so the aim of this fund is to support small collaborative research projects that address the worst inequalities in dementia care. And really it's about doing that in a collaborative way through bringing together groups that often work in silos and don't interconnect and share work and collaborate on research. So that's community organisations, lived experts and researchers, but really for them to come together and work through co-production. And so in terms of what projects we wanted to fund, all of that co-creation work and the policy lab outputs that kind of form the foundation of our vision also form the foundation of the priority areas through which we'll fund through the Small Research Projects Fund. And you can see there that the areas that we're interested in that were important from across all of the work that we did was about raising public awareness and addressing stigma and exclusion, supporting families, friends and unpaid carers of people living with dementia, building a compassionate, skilled and supported workforce, and then inclusive uses of technology. And so that was the starting point really of the Small Research Project Fund. And this was basically the way in which we can start to address those inequalities. But then what we had to do, and then what we did and what we are doing across the network, is really co-producing the funding scheme, inspiring people to engage in it and supporting them in that co-production of their ideas and research proposals. And so you can see here that the timeline, it's a timeline, but it's also kind of a big picture overview of what our Small Research Project Fund looks like. And so what we did was we started with expressions of interest. And so what we asked people to do, whether it was lived experts, community partners, practitioners, researchers, whoever they were, if they had an idea that fell within the priority areas that we were looking to fund, that they were passionate about or thought was important to pursue through small research projects, to submit them to our expressions of interest. And so we shut our expressions of interest on the 11th of July, and we were quite surprised by how many applications we received. So we received 82 applications, and those applications were at different stages really. So we had some where we had fully formed teams and close to very fully formed ideas of small research projects. And then we had some which were people with ideas and no teams, or people with ideas and sort of a team, but not the sort of skills and assets that they needed across those teams to really pursue their small research project. And so it was quite a varied collection of expressions of interest. And so what we did as a network after we'd received them was we started to match people together based on shared interests and goals. And there was a kind of a multi-pronged approach for doing that. So we matched EOI applicants with each other based on shared interests. We matched them with co-applicants on the Empower network, and also used our own personal networks to start matching people together. The idea being that we could start connecting together those collaborative teams of community partners, researchers and lived experts. And to further support that matching, we held a sandpit event on the 26th of August, in which 100 people attended both online and in person. And again, that was to really act as a platform to start connecting those groups and for them to start working together, to start further developing their ideas that they might have started to collaborate on. And that marked the launch of our full application stage, but also our co-production support fund. So throughout this process, one of the important steers that we had from across the network was the realisation really that co-production takes time, but it also takes resource and expertise. And so we really thought carefully about how we could support those teams in co-producing both their application, but also putting them in a good position for those projects that get funded to deliver projects that were grounded in co-production. And so we held co-production training webinars, we developed a co-production toolkit to support them in that, and also launched a co-production support fund. And that was really where people could submit to between £500 to £1,000 to resource financially the co-production work that they'd put in developing their small research project. And so we received, it says 20 there, but we received 21 applications for our co-production support fund. And what was quite nice about some of those applications is we could see that some of those teams were kind of offshoots through the matching process that we'd been doing through July to August. And that's where we've landed now in terms of we've got teams doing their co-production activities and they'll submit their applications on the 7th of January. But it's just to mention as well that all of this process, including the big picture thinking, so the actual process itself, and also the finer details in terms of the wording of application forms, how things were framed, were co-produced. And the way in which we did it was through convening working groups. So one of those working groups was the Small Research Project Working Group, and that comprised of 13 members, a mix of community organisations, lived experts and researchers. And we met 4 times to discuss this process with the aim of working together to make it accessible and to be able to design it in a way that could engage all those different groups that we wanted to engage. What we didn't want to happen was that we created a funding scheme that was just more of the same and that only researchers applied for essentially. But aside from that, we also convened a working group for the co-production training. And again, that was community organisations, lived experts and researchers who had expertise in co-production, who met twice as a group between May and June. And that was really to develop that co-production training that we delivered to support people in their small research projects. And so that's a kind of a quick whistle-stop tour of what we've been doing over the first year and a half of the Empower Dementia Network. And so in wrapping up, it's just really to say 2 things. One, to say thank you to all our partners and collaborators, of which there are way too many to name them all individually, but you get a taste of who they are and how many of them there are through this slide. And they're the bread and butter of the network really. Without their engagement, what we're trying to achieve doesn't work. So just to say thank you to them. And then to invite you all to engage really, there's our email address if you have questions. Please ask questions in the Q&A, and that QR code will take you to our website, which we can put the link into the chat as well. And have a look on the website. There's plenty more information on there about what we've been up to, what we've done, where we're going, what we're doing, all of that sort of stuff. So I'll stop there and I'll hand back over to Emily to summarise and open things up for questions. So thank you, everyone.
Wonderful. Thank you so much, Catherine and Andy. That was a really detailed presentation about the Empower Network, and yeah, it gives us lots to think about, I guess. And I think the thing that really comes across through both presentations is that element of co-production and consultation, and really inviting that lived experience expertise to the table to help us shape our research projects and sort of the areas of focus moving forwards. So we've got about 50 minutes, I think, before I need to hand back to Morag. So we've got some time to answer some questions that have come into the Q&A. So please do, keep posting them in there, and we'll make sure we can get those answered. So the first one is for Jan and Karen, and it says, what will be next steps from your perspective for the Parkinson's project? And will the report feed into any particular areas of work by the Department of Health and Social Care?
Jan, do you want to start?
Well, just to say that we are currently summarising our findings from a more detailed sort of dive or dip into those areas of research funding. So, for example, within the care area, we've drawn out all the themes of the research that's been done in that area with a range of sub-themes, and it puts us in a good position to give a really detailed picture of the research that's being done. And we've also had a look at some reports of what people living with Parkinson's disease would like to see research focus on, so we can compare what we found in terms of where the research focus and grants are going with what people feel are the priorities. So in our reports to Department of Health and Social Care, we'll be able to emphasise any gaps, and our hope would be that that might promote more focus on those areas that are missing, which might include end-of-life care. Karen, I don't know what you'd like to add.
I think absolutely agree with all of that. The good thing about policy research units is that we do have a direct route to pass on those policy recommendations. And as Jan explained right at the beginning, this was a requested project as part of our policy research unit. Now, the challenge is often how far those recommendations become implemented. And as we all know, cost is often a negating factor, but the recommendations often for what projects may be appropriate and how those projects should be delivered, as Catherine and Andy highlighted, those relational aspects of interventions, which are so important, are usually taken on board. But as we also know, the time taken from finding evidence-based research to implementing evidence-based research is on average 17 years. What we're trying to do with the policy research units is shorten that time frame for implementing change. So we do pass it on. It is read, it is discussed. Our policy partners and our stakeholder network discuss that, but how and when it is implemented, like much, we have less influence over.
Excellent. Thanks both for a very comprehensive answer. And it's really exciting to kind of think about what's next for this project as well. And I think just from the slides that you shared today, we know that there are gaps, and it's how we portray those gaps and we, really amplify where the future research is needed. So thank you both. We've got another question here from Caroline. So at Parkinson's UK, we've published a prevalence study looking at GP records. My question is, should there be a modern service framework for neurology and including Parkinson's, which could address what good care should look like?
Can I take that one? Is that meaning a strategy? Is that what we've been asked?
So similarly to the modern service framework in dementia and frailty, I guess the question is, should there be a similar framework for neurology, which kind of maps out how service provision should be?
I might hand over to Jan and Karen then for that one.
Happy to take that. And Emily, I'm sure you have a voice on this as well, given you're part of the neurology discussion group. From what we understand, and again, with policy being often coming in from left field, if I'm not being too controversial, this may change, but there is certainly a specification, a recent specification service framework for neurology. And Emily, perhaps you want to just describe a little bit about the work that you're doing around the equity in neurology and wider service frameworks.
Yes, yeah. So there is a piece of ongoing work looking at neurology transformation across NHS, and I think what's really important is for us to highlight the need for consistency and a consistent approach and of the service sort of specification that can be at local and national level to make sure there's equity in access to, but also in provision of care services. So from that prevention all the way through to end of life care, making sure there's that consistency there. So I absolutely agree with Caroline, and also Sarah's commented on that question as well, and we really do hope there is something in the future that's a modern service framework on neurology. I don't know if Jan wanted to comment as well on that.
Just briefly, I was thinking that the National Service Framework for Dementia in the past did play a big part in shaping dementia services. So it sort of highlights that the next incarnation of modern service frameworks probably will have a big influence. I was listening on Radio 4 this morning to a discussion about the hospice movement and the financial problems within the hospice movement. And one of the issues highlighted there was the variability across commissioning decisions being made by the different areas of the country by the integrated commissioning boards. So if frameworks can help to get some consistency, I think that's very helpful for people in different regions of the country.
I think what's really important, though, the dementia strategy that we had back in 2009, which was very welcome, very much focused on the timely diagnosis, and there was very, very little about care. And that has been a consistent challenge, really. And then, understandably, from a societal perspective, there still remains poor understanding that these are terminal progressive conditions. And until there is really that societal understanding and appreciation, advocating and championing for palliative and end-of-life care for these populations is just really tough, because there's not a recognition that all of these individuals are going to die with their respective dementia or Parkinson's disease, but we really lack the attention to what happens to individuals and ensuring there is that equity of care provision up and down the country, which at the moment there isn't. And I think your point about the variability in the commissioning speaks to that you can be in some areas of the country, like for example in Derbyshire, they have a fantastic dementia palliative care community team. It's the only one that exists in the entire country, and that's very much been around advocates championing for the provision of palliative care for people living with dementia, and the backing and the support of their respective commissioners. And also equally important, the demonstration of the service on the outcomes, the difference that makes for patients and families, and also the economic messaging around providing that high quality care in the community.
Yes, and you also made me think of the service complexity, because this issue of the need for integration comes up time and again, but a sort of paradoxical consequence in some ways of the emphasis on raising the number of the proportion of people who have dementia receiving a formal diagnosis was that diagnostic assessment and diagnostic services were sort of cut off from the rest of the care pathway. So one of the impacts of that emphasis may have been that there was actually less continuity of care and less integration of care following diagnosis. So thinking about that complexity to get integration is, a very challenging issue. Yeah.
Yeah, I think that continuity of care right from the point of diagnosis. I mean, it's often said dementia, I think, is probably the only condition in which you receive a diagnosis, and then for many people, they're then advised to contact their GP should they experience any problems. Again, very variable. Some services are fantastic at the point of diagnosis and they very much connect and support, while others there is little or nothing at that point of diagnosis.
A really interesting discussion to be had. So I guess we'll watch this space and see what happens. But there's definitely that need for consistency in equitable access. I did see a question go into the chat, which I think, Catherine, you did respond to, but I didn't know if you wanted to bring that to the discussion here. So there was a question regarding for when to engage with end-of-life support. What role does the SPICT criteria play in informing that issue?
So I think as I popped in the chat, and thank you, I think it was Alan Barton who raised that in the chat from the London Ambulance Service. I think SPICT is really important, and if somebody can put in the chat what the acronym SPICT actually means, I think that might be very helpful for everybody. So PICT is essentially a prognostication tool used across many different diseases, so dementia, cancer, organ failure, and it is really helpful in identifying individuals really with an advanced disease. And for me, when I look at that, I think, oh my goodness, if we cannot get it right for these individuals, then what are we doing? Absolutely. You know, the detail on dementia, I think, is with somebody who by that point is bedbound, is incontinent. You know, they have very advanced disease stage, and you absolutely want at that stage that the benefit for that individual and their family of provision of palliative and end-of-life care, absolutely that's what should be happening. But even at that stage, people are still not accessing palliative care. Sometimes it can be in the dying stage when somebody's actively dying that the benefit and the need for end-of-life care is recognised. And as I popped in the chat, the SPIC tool is very much based on prognostication, so your disease stage, really what's happening to you. And we know in dementia that about 2/3 of people die earlier. They die from an unrelated morbidity, or they die from a complication in relation to their dementia. So just as Jan and Karen were saying at the beginning of their presentation, the huge inherent uncertainty as to when individuals can benefit from palliative and end-of-life care means that we very much advocate more of a needs-based provision. So as people have, for example, increasingly complex symptoms or psychosocial concerns, it's very much at those points that you want care to be orientated towards quality of life. You want care very much to be around person-centered and relational care, which is exactly what palliative care is. So it's that needs-based approach of when you are wanting care to be focusing on quality of life. Karen, did you want to?
Yes, completely agree with all Catherine has said. It was interesting within the consultation, toolkits weren't even mentioned. And I think that is the inherent uncertainty around prognostication that Catherine has highlighted. But toolkits do step away from that relational person-centered care approach, while having a guide for multidisciplinary teams may be helpful. For those that we spoke to, and I believe from the literature, what was important was the communication and the information at the right times in the right place, not whether or not a toolkit was applied. And I'm not negating the usefulness of such tools. Jan?
I think that the specialisms of dementia care and of palliative care have an awful lot in common in terms of their value base. I think both really value and try and put into practice person-centred and relationship-centred care that takes a person's context and life into account. But I think one of the things is that underlying that, they have complementary areas of expertise that they can bring together, which really can make the last part of someone's life better. The people working in dementia care may really understand what it's like to communicate with someone without cognitive capacity, to understand how to help with aspects of behaviour that may be difficult, and the people from palliative care will really understand about expressions of pain, about use of medication. And so I think both are concentrated on those values, but the trying to bring them together to provide the integrated care is what can give people a better quality at end of life. Yeah.
Excellent. Thank you so much for your responses to those questions. We do have one more question in the chat, but we are quite tight for time, so I'm going to have to draw us to a close. But George, we'll take that question away and make sure that that's followed up and you get a response to that. So I will be handing back to Morag, but firstly, can I just say thanks to everyone for joining us, and also thanks to all our speakers. It was brilliant to have you all on board today. So back to you, Morag.
Wonderful, thank you so much. So I'm just going to pop back on our slides and just to sort of tell you about our next webinar, which will be, apologies, I've got the wrong one, which will be on the 18th of November, about developing inclusive practices around consent and mental capacity in palliative care research, which I think will be a fascinating discussion. It's a session that's being run by Dr. Caroline Barry and Dr. Victoria Shepherd. And just to sort of remind you that if you want to access recordings of previous webinars, you can do so through the link that's on the slide. So the final thing that we would like to ask you to do is to do a very brief evaluation of today's webinar and the webinar series. And just to remind you that we really welcome suggestions for topics for future webinars. These webinars are only as valuable as they are for yourselves if you're able to let us know topics of interest, and then we can explore potential speakers to speak to those topics. So please do let us know some ideas. So I'm just going to finish by thanking our speakers and our chair today. It was such a fascinating discussion, and great to see so much interest in the chat in terms of engagement with the topic. So thank you everybody, and hope everyone has a really good rest of their day.
Thank you everyone, great that you joined us.